So in this particular section, we are going to discuss on the coagulation pathway in detail. That is going to involve the clotting factors. But anyways, I'm going to give a bird's eye view on what is overall happening, because without this bird's eye view, it's very difficult to understand all these extrinsic and intrinsic pathways. So whenever you call the word hemostasis, you are going to have two types of hemostasis. One is called primary hemostasis and second one is called secondary hemostasis. In the primary hemostasis, it typically involves the platelets and they're going to form something called a temporary platelet plug. And in secondary hemostasis, it's going to involve the clotting factors and they're going to form a stable fibrin clot, which we'll discuss. So this platelet activation is based on two processes. One is called primary activation and secondary activation. You know very well, primary activation is mediated through your platelets glycoprotein receptors and platelets PAR receptors, which are going to attach with your endothelial collagen, von Willebrand factor, and thrombin. You know, glycoprotein receptors are important for attaching with collagen and von Willebrand factor, and PAR receptors are important for attaching with an element called thrombin. So next, you have something called ADP release. This ADP is the one that activates a very important enzyme. Apart from other purposes, they are going to activate a very important enzyme called thromboxane A2 synthase, which is going to increase the production of thromboxane A2. This increased production of thromboxane A2 is the one that forms the main purpose of the entire secondary activation. That is the one that's going to boost up the platelet activation process. That's boosting. So you can remember primary as initiation and secondary is a boost. And it's going to keep amplifying them unless and until the defect is sealed. Anyway, whatever may be the reason, whatever may be the mechanism or whatever may be the reason, I told you so much of numerous mechanisms in the previous section, but whatever may be the mechanism, the final thing is going to increase the granule content release. They're going to empty the granules, and second thing, they're going to increase the expression of a receptor called GP2B3A. Expression is going to increase. Clear? So this is what is happening here. So this is the entire platelet plug. By this, they are going to form a temporary platelet hemostatic plug. But stable fibrin clot is important. Who is going to form? This is the clotting factor pathway. So the clotting factor pathway also has two types of processes. One is called an extrinsic pathway. I will consider extrinsic is more important than intrinsic, because extrinsic is the one that starts, that is the one that's going to initiate the entire process. So let us put the extrinsic in red because it's the one that starts, the one that's going to initiate the entire process. The extrinsic pathway, obviously, it ends at somewhere called activation of factor 10. This factor 10, very important, they're going to activate a very important substance called prothrombin to thrombin. So remember, let us put this red shade, red shade here to everything, because these are all our extrinsic pathway related things. Remember, the thrombin that is going to be produced through this extrinsic pathway, it's not enough to activate what? Fibrinogen to fibrin. This is the final step. This is what happened. But this thrombin that is produced during the extrinsic pathway is not enough to activate fibrinogen to fibrin, because it will be produced in very, very, very little amounts called picomolar productions. Picomolar amounts. Very small amounts of thrombin produced, which is never going to be enough to convert fibrinogen to fibrin. But then why you are producing this small amounts of thrombin through extrinsic pathway? Because this is the one that gets activated first through tissue injury. Because tissue injury is going to activate your tissue factor, release of tissue factor will be there, and that is the one that starts the entire process of this secondary hemostasis cascade itself, and that's the one that forms the first thrombin molecule that are going to generate. Clear? So very small amount of thrombin. But why this very small amount of thrombin is important? Because this small amount of thrombin has so much of purpose, because it's going to activate an entire pathway called intrinsic pathway of coagulation. Let us put everything in blue here. Remember, this intrinsic pathway, what it is going to do is, again, it's going to result in a cascade only. But who serves as the primary source for activating this intrinsic pathway is the thrombin that you have actually generated through the extrinsic pathway. And similarly, who's going to activate the PAR receptors of the platelets here? It is the same thrombin that you get through the extrinsic pathway. So this extrinsic pathway thrombin is important for platelet activation also. This extrinsic pathway thrombin is important for entire intrinsic pathway activation and boosting also. Because this intrinsic pathway is the one that is going to form a blast, like, it's like a cracker you can take. Initially, when you put the cracker, only small thing will go, like small piece of fire will go. Once, it gets boosted, it's going to blast like anything. So you can imagine like initial, like a matchstick, and you burn the cracker is like an intrinsic pathway. So slowly it goes and then in final burst you can activate like an intrinsic pathway. The initial one is the extrinsic pathway. So that small amount of thrombin that is generated through the extrinsic pathway is going to amplify the intrinsic pathway. So intrinsic pathway is the one that's going to get fired up and they're going to get amplified and they're going to get activated. And where it going to terminate, if you amplify this intrinsic system, again where it's going to end up is in the same zone. That is, they are going to activate the 10A again. They're going to activate the 10A again. They're going to activate the factor 10. And this activation of factor 10 again is going to result in conversion of this factor 2 to factor 2A, which means they are also going to produce the same thrombin only. They are also going to produce same conversion of, you can put everything in blue here. So they are also going to convert the prothrombin to thrombin. And the amount of thrombin that is generated through this extrinsic pathway is enormous. It is almost billion times higher than what you produce during the extrinsic pathway. So this thrombin is definitely enough to convert the fibrinogen to fibrin, and they form a stable fibrin clot. So with the help of factor 13, obviously, that's called fibrin stabilizing factor. So they can form a stable clot. And this clot will be further dissolved by something called fibrinolytic system, which we'll discuss later on. Fibrinolytic system, which we are going to discuss later on. And this thrombin's function is multifold actually. The thrombin that is generated through this processes. For example, you can see, let us put a common thing, thrombin that is generated. This 2A's function is multifold because the first function of 2A is the amplification of the intrinsic pathway. Amplification of the entire coagulation cascade through the intrinsic system. Second, it's going to activate the platelets also through PAR receptors, which we discussed already. And third thing, this is something you will not understand, this thrombin is the one that is going to also activate the anticoagulation system. Because the moment you produce a burst of these many coagulation cascade, there's a lot of pathway that entire blood will be coagulated in a fraction of a second. If you produce this much of billion times and that will activate more and more billion thrombin molecules, that billion of billion will again activate more trillion molecules of thrombin. You might result in a, within an instant, your entire blood vascular system will get coagulated and clotted. So to avoid that, you have to activate the clotting system also, because thrombin is the one that activates this protein C molecule as well. Very important. At the same time, this also activates the fibrinolytic system. This thrombin is the one that also activates the fibrinolytic system, which means it also quickly helps in the dissolution of the clot also, which means the clot is formed, a defect is sealed. Once the clot is no longer needed, it has to be dissoluted, and that also is one of the important functions of the thrombin, which means the thrombin is the one that is going to have one of the major function. At the same time, you can see everything comes to a halt at the 10A level. So both the intrinsic pathway also comes to conclusion at the 10A level, the extrinsic pathway also comes to a conclusion at the 10A level. From there only a thrombin will be activated. That's something secondary. So that's why this 10A is also referred to as something called a common pathway, like what we saw in the complement system. In the complement system, we saw C3 convertase, that C3 is the common pathway there. Similarly here, this 10 is the common pathway. 10A formation is the common pathway here. And finally, fibrinogen formation is the terminal pathway here. But anyway, intrinsic as well as extrinsic. Remember, intrinsic is the one that initiates, extrinsic is the one that initiates, and intrinsic is the one that's going to amplify this entire coagulation cascade. So this is the entire thing. You should not confuse between this primary platelet initiation and primary platelet activation, secondary platelet activation, and primary hemostatic initiation and secondary hemostatic activation, that is intrinsic and extrinsic pathway here. And similarly, you should not confuse the primary and secondary hemostasis also. A lot of primaries and secondaries are there, but don't get confused. All are entirely different, but all are trying to achieve only one thing, that is a closure of the defect and thus sealing the defect. So the problems that arise due to this platelet, this temporary hemostatic plug formation, are going to be causing something called a bleeding disorder. This is the basic. They are going to result in something called bleeding disorders, which has its own characteristic clinical presentation, which we'll see separately. And the problems that are going to cause problems of the coagulation cascade, either intrinsic or extrinsic, is going to be called as clotting disorders. which has its own clinical way of presenting, how they're going to present, which we'll discuss separately. Remember, there are a lot of things that are going to result in this platelet dysfunction bleeding disorders, which is not confused with the clotting disorders. The first one being the thrombocytopenia. Thrombocytopenia or any functional defect of the platelets, like your Bernard-Soulier syndrome. These are functional defects. These are not actual platelet defects. These are functional defects. Bernard-Soulier syndrome, uremia. Uremia is a very important platelet toxin. They don't cause thrombocytopenia, but they reduce the function of the platelets. Then you have Glanzmann's thrombasthenia, which we discussed already. Then platelet storage pool disorders like delta storage pool disorder, then gray platelet syndrome, all these things. Storage pool disorder. Then you have a lot of other conditions also. For example, when you get thrombocytopenia into other causes. So these are some of the important reasons why you're going to get a bleeding disorder. And similarly, you can get a lot of disorders due to clotting factor dysfunction. And a lot of drugs, we didn't say about the drugs, isn't it? So let us see the drugs over here. Come back to the drugs here. So let us see the drugs over here. So a lot of drugs can cause, for example, these are aggregation inhibitors like COX inhibitors, aspirin, P2 vital inhibitors, your clopidogrel and prasugrel group. Then you have your PAR inhibitors. These are Vorapaxar, and you also have GP2B3A antagonists. These are abciximab, tirofiban, and eptifibatide. We discussed already. So all these things are going to inhibit the platelet function prominently, and these are typically, we discussed in the previous video itself, these are aggregation inhibitors. And similarly, you have clotting disorders. Typical clotting disorders include congenital defects that cause hemophilia. We have both A and B, deficiency of factor 8 and factor 9. Factor 9 defect is also referred to as Christmas factor disease. Anyway, factor A and, hemophilia A and B, factor 8 defect as well as factor 9 defect is there. 8 is very, very common. Congenital clotting factor deficiency, factor 8 is the most common. You have acquired clotting factor deficiencies also, like you can get in liver disease, you can get in DIC, a lot of other acquired clotting factor defects are there. Next, you might also get with a lot of drugs that you see. Drugs, for example, you give warfarin, you're going to give your heparin group, heparins, then you have your thrombin inhibitors, which are both direct and indirect are there. Then you have factor 10E inhibitors. A lot of drugs are there. These drugs are going to inhibit the clotting factor mechanism. It's also important to understand that these disorders are completely different what you see on the platelet disorder side, and these disorders are completely different what you see on the clotting factor dysfunction side. But wait on. One disease you might be expecting, but it's not seen here. What is that disease which I have not told? That is nothing but a von Willebrand disease. Von Willebrand disease. I didn't tell because this is something acts as a bridge between a bleeding disorder and clotting disorder, because von Willebrand disease, it's typically a bleeding disorder. That's what you expect. Yes, it does present as a bleeding disorder, but it can also have a confusing picture like a clotting disorder also. Why? Because it can have both the clinical features of a bleeding as well as clotting disorder because of its functions. If you ask me what are the important functions, we have a whole lot of thing to discuss on von Willebrand factor, but still if you ask functions of von Willebrand factor, the number one function is acts as a platelet glue, which means it's going to bind with the collagen and the platelets through GP1B interaction. So second one, it's also going to bind with factor 8. Factor 8 binding, that's a very important function. Like for example, it's going to hold the factor 8 like a kangaroo, and it's going to protect it from external damage, which means it's going to increase the half-life of factor 8. For that, von Willebrand factor is really, really important, which means it can give rise to a disease that is similar to platelet dysfunction. It can give rise to a problem that is similar to clotting dysfunction also. So depending on what type of von Willebrand factor you are dealing with, because von Willebrand factor, this von Willebrand disease itself is a separate entity, which has a lot of other different types are there, but we'll discuss later on. So it's something that you can tell in between a bleeding and a clotting disorder, which can predominantly present the bleeding disorder, or can predominantly present the clotting disorder like hemophilia, or can present with both the features also. So it is different. So this is all about a bird's eye view. I showed you about hemostasis and important things about it. Now, with that, let us go to the secondary hemostasis, because primary we have seen already in the previous section. Let us move on to the secondary hemostasis. So what do you mean by a secondary hemostasis? Secondary hemostasis, I told you there are two pathways. One is called an intrinsic pathway. It is the one that initiates all this process. So let us finish off the intrinsic pathway. Intrinsic pathway, the first thing I told you, it's going to be from the tissue factor. It is resulting from tissue damage or vessel damage or anything. Any tissue damage or vessel damage is going to cause release of tissue factor. And this tissue factor is going to convert this factor 7 to factor 7A. And they're going to activate this factor 7 to factor 7A. And whenever I tell this active factors, 7A in this group, A means it's activated, which means these majority of them are going to act as serine proteases, which means they're going to cleave a protein fragment or an amino acid fragment from a different protein, and they're going to activate them by cleaving the fragment separately. Which means 7A is also one of the examples of serine protease. This 7A is going to definitely do one important thing, that is conversion of this factor 10A to 10, factor 10 to 10A, which means it's going to cleave the 10 to 10A, which means it's going to activate the factor 10A. So everything now we can put as a pathway of extrinsic system. So this is going to activate 10A. I told you, once the factor 10 is activated through extrinsic mechanism, that is going to cause activation of thrombin, that is from factor 2 to 2A. So again we can put in red, 2 to 2A. So this is going to convert prothrombin to thrombin. And remember, this is not enough to convert your fibrinogen to fibrin. This is not enough actually. This cannot form because they are formed, as I told you, only in picomolar concentrations. But this is going to amplify the intrinsic system. The small amount of thrombin that you are generating through the extrinsic pathway is going to amplify the entire intrinsic pathway, and they are going to produce billion times more thrombin. So let us write the intrinsic mechanism here. Intrinsic, let us keep a color code of blue, and extrinsic we can keep a color code of red here. So once you take the intrinsic system typically they are going to initially start with your factor 11 activation to 11A, that is the start here. So factor 11 is going to get activated to something called a 11A. So who's going to activate this? This small amount of thrombin that you have generated through your extrinsic pathway, that is the one that is going to the same thrombin that is coming from here. So that is the one that is going to activate your 11 to 11A. This 11 also can be activated directly by your factor 12, activated factor 12. That's called 12A. So who's going to activate 12 if you ask me? This 12 to 12A conversion will be mediated by your exposed collagen, which means it's a basic thing. How you are going to activate the platelets, same mechanism is going to activate 12A. Your collagen, your base membrane, your platelets that are activated platelets, base membrane, collagen, all these things itself is going to activate this factor 12 to 12A formation. But that is not important. The most important thing I want to tell is this 11 is the starting here. Many books will give you 12. I don't believe in 12. 11 is the starting of the intrinsic pathway, which is going to be activated by thrombin, which is coming from the extrinsic pathway initially. So this 11 is going to further form a cascade. So it's going to convert this active factor 9 to factor 9. Clear? Again, these are all our extrinsic pathway mechanisms. We can put everything here. So extrinsic pathway mechanisms, all these things, all are extrinsic pathway. So 10 to 10, 9 to 9A conversion now. So once this 9A is formed, this 9A is going to now convert this factor 10 to 10A as usual. Like what 7A did there in extrinsic pathway, this is going to convert this 9 to 9A. 10 to 10A. So which ends up with the culminates in the common pathway. So you're going to get 10 to 10A, 10 to 10A. So that's what it is going to form. So the moment your 10A is formed, this 10A is going to further, amplify, very well. It's going to form factor 2 to factor 2A, which means it's going to convert the prothrombin to thrombin. So the thrombin here that is generated is billion times more than what you have generated in the extrinsic pathway. So this is enough to convert the fibrinogen to fibrin, and initially it will be monomeric fibrin, it will not be polymeric. So now there is something called cross-linking should happen. This monomer should form cross-links, fibrinogen cross-links. This is the one that is going to be strong. Cross-links of fibrin will be formed, and this cross-links of fibrin should be activated by a important factor called factor 13. That is the reason this factor 13A is also referred to as something called fibrin stabilizing factor, because this is the one that connects the monomeric fibrin and causes the cross-links and produces this cross-links of fibrin and forms a stable clot. You might ask me who's going to activate this factor 13. Again, it's a no surprise. Your thrombin is the one that is going to activate your factor 13 as well. So this thrombin that is coming from the extrinsic as well as intrinsic pathway is the one that is going to activate this factor 13 also. So such is the importance of the thrombin and the impact of thrombin in the coagulation system. Clear? At the same time, next if you ask me, sir, you have not told about a lot of factors. First of all, you will understand there is nothing called factor 6. That's out of the question. At the same time, you didn't tell about factor 8 and factor 5. Very valid question. So where are factor 8 and factor 5 in the intrinsic system, which are very, very important. So first, let us assume you need this factor 10 conversion to factor 10A. Remember, for factor 10 conversion to factor 10A, this is what we call a common pathway. We discussed already. So this particular area where factor 10 is converted to factor 10 is converted to 10A, that's active factor 10. This is what we call a common pathway. So this 7A converting this 10 to 10A doesn't need a cofactor. But this 9A converting this 10 to 10A needs a cofactor. It cannot do it alone. It needs a company. That is activated factor 8. It's very, very important. So this activated factor 8 has to come from previously inactivated factor 8, that is inactive factor 8 that is present along with the von Willebrand factor. But who is going to activate this factor 8? Again, it comes as a no-brainer. It is nothing but the thrombin. And what is this thrombin? This thrombin is nothing but that is generated through the extrinsic system. So that is the reason why the initial starting thrombin that is generated through the extrinsic system has a tremendous impact on the entire intrinsic pathway. It's going to activate at multiple steps and is going to enhance and boost the coagulation system dramatically. And next thing, you also need one important thing, like this factor 2 getting converted to 2A. It can happen with factor 10A alone, but conversion of 2 to 2A into major amounts, this major lot of amounts, I told you billion times, like more thrombin is produced in the intrinsic pathway compared to the extrinsic pathway. But how is that possible? The same 10A produced here, but how it can produce that much higher amount of thrombin? It is because you have one more cofactor in the intrinsic pathway that can augment this process entirely, is something called factor 5, activated factor 5. Obviously, you need this factor 5 to come from prior inactive form. And who is going to form this factor 5? Activated factor 5. And again, as a no surprise, it's going to come from the thrombin. Again, where is this thrombin? This is the thrombin that is produced in picomolar concentrations during the extrinsic pathway. That is the one that is going to activate this factor 5 also in the intrinsic pathway. So you can see this small thrombin that is generated through the extrinsic pathway, it has dramatic effects on the intrinsic pathway as a whole, and that is the one that is going to produce billion times more thrombin. Clear? Thrombin producing more thrombin. That's the idea. Fine. So these are the two cofactors. I can put the cofactors separately, maybe in a different color. I can put pink here. So these are the cofactors that are needed. Apart from that, you need other thing for this clotting system that is called calcium and phospholipids. Where you need calcium and phospholipids? You need calcium and phospholipids at this step, this 7 conversion to 7. For activation of 7, you need for calcium and phospholipids. Similarly, for activation of 10, you need calcium and phospholipids. Similarly, for activation of 9, you need calcium and phospholipids. Similarly, for conversion of prothrombin to thrombin, again you need calcium and phospholipids. So this step also needs calcium and phospholipids. But where you need calcium and phospholipids the most, if they ask you, is the 10 to 10A conversion. That is where the calcium and phospholipids are of tremendous importance, from 10 to 10A conversion. So you can see one important association here. You have this factors 2, that is prothrombin to thrombin conversion. Then you have 7, that is 7 to 7A conversion. This happens in the extrinsic pathway, isn't it? Then you have 9 and 10. So you know 9 is nothing but intrinsic pathway and 10 is in the common pathway. So you have these factors 2, 7, 9, 10. So these are the factors that are dependent on calcium and the phospholipids. Am I right or not? Incidentally, you can also note these factors are nothing but vitamin K dependent clotting factors. These are also nothing but vitamin K dependent clotting factors, which means vitamin K dependent clotting factors are not only vitamin K dependent for production, but for activation, they are also dependent on the liver. depend on the calcium. Please do understand, for proper production of these clotting factors, you need vitamin K in the liver. For proper activation of these clotting factors, you need calcium and phospholipids. That is how your EDTA is going to chelate the calcium in the blood and makes this calcium unavailable for this 2, 7, 9, 10, which means these factors will not work and the blood will remain in the fluidic state. It won't get coagulated. That's how the EDTA also works. Anyways, so you can understand that the important association. I can tell this calcium and phospholipids are also important for this 9, 10, 2 and 7. Clear? 2, 7, 9 and 10. You need this calcium and phospholipids also, but the most important for the common pathway, that is activation of factor 10. So what is the association? Now you can ask me one question, sir. You told they are calcium dependent in the periphery and vitamin K dependent in the liver. But what is the relationship? Is there anything that connects this calcium and vitamin K? Yes, it is. So that is why it is important to understand. So what is the connecting thing between the calcium and the vitamin K? So first, let us see how vitamin K will activate this clotting. Important for the generation of these clotting factors in the liver. So we can take these clotting factors, that is 2, 7, 9 and 10. Clear? And you have this vitamin K. Typically, you have in hydroquinone form initially. You have something called hydroquinone form. This vitamin K hydroquinone form is going to get converted to something called a vitamin K epoxide. This conversion to vitamin K epoxide is really important for one reason. Let us put the conversion from vitamin K hydroquinone to epoxide formation is really important because this conversion is mediated by an enzyme called gamma glutamyl carboxylase. Gamma glutamyl carboxylase. During this crucial step, your clotting factors are actually carboxylated, which means you are going to add a COO minus. So which means these clotting factors initially they are uncarboxylated. Later on they are now carboxylated. This carboxylation of clotting factors is very, very, very crucial because this 2, 7, 9, 10, as I told you, they are calcium and phospholipid dependent, which means they are predominantly calcium dependent. So this carboxyl addition is the one that attracts the calcium because this is a double negative carboxyl is going to attract the double positive calcium, and this is very, very crucial for coagulation. That's why these factors, this carboxylation is the main step, that is the important step that going to capture this calcium ions for their activation in the periphery when it is needed for coagulation. So this is the association between vitamin K and calcium, carboxylation step. That's a crucial step. And this vitamin K epoxide should actually shuttle back to hydroquinone form, and this is actually NADH dependent because during this step your NADH will become NAD and NAD plus because NAD and H plus. This is because this epoxide has to convert to hydroxyquinone, means you need a very important enzyme that is called vitamin K epoxide reductase. Since it's a reductase enzyme, you need this hydrogen ions that is going to come from NADH only. It's a very important reducing agent. So this is what is going to happen. So remember, this replenishment of hydroquinone form is really important for future carboxylation reactions. If you don't replete this hydroquinone active vitamin K form, this you can even tell it's an active vitamin K form. So if you don't replenish that, your carboxylation is not going to happen. So that is how your vitamin K antagonists come into play. For example, your vitamin K antagonists, these are nothing but epoxide analogs, vitamin K epoxide analogs, these are nothing but coumarin derivatives. Best example is warfarin. You have acetylcoumarol also, but best example is warfarin in this group. They are going to block the vitamin K epoxide reductase enzyme by fooling the enzyme to think that it is vitamin K epoxide. So which means it is going to inhibit vitamin K epoxide reductase by competitive inhibition because of the similar structure, like similar to that of vitamin K epoxide. Clear? So that is the reason why when you increase the active vitamin K levels, more and more epoxide will be formed, which means it can overcome the competition. That is why antidote for vitamin K antagonist is vitamin K itself. Very simple, because of the competitive. If it's non-competitive, you can't do anything, but it's a competitive inhibition, so you can overcome the inhibition by giving vitamin K, which is going to act as an important antidote for this coumarin derivatives. So this is the association between carboxyl group and carboxylation, vitamin K and the calcium step. So that's why they are related to calcium. And this 2, 7, 9, 10 factors are also referred to as something called the prothrombin group. These are also referred to as something called the prothrombin group. This is one important understanding. This is also referred to as something called a prothrombin group. So if you call this as a prothrombin group, what is the other meaning? That it is not dependent on thrombin. That is also very important. It is not going to be dependent on thrombin. It is not dependent on thrombin. That's a very important point. Clear? At the same time, one more important thing that you have to notice, there are some other clotting factors that are dependent on thrombin. You can see what are the clotting factors that depend on thrombin. You can see this factor 11 dependent on thrombin. Then your factor 8 dependent on thrombin. Then factor 5 dependent on thrombin. Then this factor fibrinogen is dependent on thrombin, because fibrinogen directly you can see this is actually thrombin dependent only. This fibrinogen conversion to fibrin is mediated by thrombin only. Then your factor 13 is also dependent on thrombin, which means you can write this factor 1, that is fibrinogen, is factor 1. Then you have factor 5, then factor 8, then you have factor 11, then you have factor 13. So you can tell all these factors are actually thrombin dependent. So that is why these are also referred to as something called thrombin group. These are also referred to as thrombin group 1, 5, 8, 11 and 13. This is very important because exam question, thrombin group. So you can see one important thing, that these are not dependent on calcium and phospholipids, hence they are not dependent on vitamin K also, because there is no need for carboxylation of these clotting factors, because they are not calcium dependent in the first place. That's why they don't need carboxylation. So these are what we refer to as something called the famous thrombin group. Clear? Because for all these you need this thrombin, that only can activate all these clotting factors. Clear not? So this is the important thing to understand, and they are not dependent on vitamin K. And where all these factors are coming from? If they ask you where all these factors are coming from, they are actually synthesized in the liver. All of them. With one important exception. One important exception is there. What is the exception? Very important exception, that is factor 8. Factor 8's origin is not from the liver. In fact, it's coming from the endothelial cells. It's coming from the endothelial cells. Factor 8 is coming from the endothelial cells. Liver means where I am talking about is the hepatocytes. Hepatocytes, that's where the clotting factors will be synthesized from, but factor 8 is synthesized from the endothelial cells. Whether factor 8 is coming from the liver or not, if you ask the answer, it can come from the liver, because liver also has endothelium, and liver has endothelium in the form of something called hepatic sinusoids. They synthesize factor 8, but actual hepatocytes will not synthesize your factor 8. It's the endothelium of the liver might synthesize, but hepatocytes don't synthesize. That is also the reason why, if they ask you an important question in liver failure, what factor is not affected? In fact, this is the only factor that is not affected even to an inch, that is factor 8 is not affected in liver failure. Similarly, when you do a transplant, you cannot correct hemophilia. Factor 8 cannot be corrected again. Even after transplant, you cannot correct this factor 8. If you have a congenital factor 8 deficiency, it cannot be treated by liver transplantation, because liver hepatocytes has nothing to do with your factor 8. Very important point again. So this is what the important interesting connection between all this. And let us go to the anticoagulants now. Because this anticoagulants is a huge section, at least one question you are getting in every year, you are getting one question from this. Anticoagulation you can divide into two steps. One is called parental group anticoagulation, parental group of anticoagulants, and second one you can put oral group of anticoagulants. What are the parental group of anticoagulants you have? Again, I can put under indirect and direct drugs. And oral group, again I can put, they are indirect drugs, and here something called direct drugs. What are the indirect anticoagulants? Indirect parenteral means typically they have heparins and probably fondaparinux. Fondaparinux you can put under heparin, but right now let us assume separately. Heparins have two, unfractionated low molecular heparin, which we will see subsequently in some time. Direct anticoagulants, you have parenteral. One important thing, that is your leach derivatives, that is your lepirudin, because they are predominantly going to act on your factor 2, thrombin, which means direct thrombin parenteral inhibitors. These are leach group. Like for example, you have drugs called hirudin, then you have something called lepirudin, Then you have bivalvulotin. Among all these drugs, the bivalvulotin remains the most important because it's used in cath lab very frequently nowadays. Then you have your ergotamine. Then there are direct parenteral factor 10 inhibitors also, which is not commonly used. These are heparinoids called as danaporoid. Remember, it's a very important thing. Heparins act indirectly. How heparins act indirectly? Because they are going to activate a factor called antithrombin 3, then which is going to inhibit the coagulation cascade. Antithrombin 3 is going to inhibit the coagulation system. Very important point. But these are direct. They directly inhibit a particular clotting factor. So 2A or 10A. Indirect, you have your coumarin derivatives. These are nothing but warfarin and acinocoumaril. Warfarin, and you have something called acinocoumaril, and we are going to use warfarin only. Clear? So how they act indirectly means how they act is through vitamin K epoxide reduction, which means it's not directly inhibiting the clotting factor. It prevents the formation of this carboxylated clotting factors in the liver. So by inhibiting vitamin K epoxide reductase. So it's an indirect mechanism, not direct. Direct means they are going to directly inhibit a particular clotting factor. You have direct thrombin inhibitors. Like for example, you have something called dabigatran, most important. You have something called Z-melagatran also, but this is not used or approved for this particular purpose. It was in the trials, but not famous now. Dabigatran is the one that is very important in this group. Then you have direct factor 10A inhibitors also. These are nothing but 3 drugs are there in this group: apixaban, then you have rivaroxaban, then you have something called edoxaban. Why I am writing like this, you can clearly see, because these are factor 10A inhibitors. That's why I am writing like this: apixaban, rivaroxaban and edoxaban. One important thing that you have to notice, these 4 drugs, these are the very important thing right now. These 4 drugs, that is dabigatran, apixaban, rivaroxaban and edoxaban. These 4 drugs are what we currently term as something called novel oral anticoagulants, because these are direct, oral and newer ones. So that's why these are referred to as novel oral anticoagulants. This warfarin are old drugs, old oral anticoagulants. These are not novel. Why we shift from warfarin to NOACs right now in majority of the conditions? Because warfarin action is quite unpredictable. Because you have to believe that warfarin doesn't only inhibit the gamma carbonation of clotting factors 2, 7, 9, 10. Warfarin, it also inhibits the activation of 2 anticoagulant factors, that are protein C and protein S, which are also vitamin K dependent. Protein C and protein S, which are anticoagulant factors, are also vitamin K dependent. So where protein C and protein S are acting, and these are natural anticoagulants. For example, if you see, you have something called factor 5 here, isn't it? So this factor 5 is the one that is actually inhibited by protein C. Protein C degrades or lyses this factor 5 so that they block the intrinsic pathway, which is the main thing for amplification of the clotting. So protein C acts, and protein S is going to act as a cofactor. Protein S is going to act as a cofactor. So protein S is nothing but a cofactor. It's going to act as a cofactor along with, but protein C is the major thing. So we have something called activated protein C. Who's going to activate this protein C? Again, I told you it is the thrombin that is going to activate the protein C. So how protein C is activated? By something called thrombomodulin. This thrombin and thrombomodulin combine with each other. So this thrombin-thrombomodulin complex is the one that is going to activate the protein C. Where protein C is present, protein C is actually synthesized in the liver, all right, but it will be actually located on the surface of the endothelium through a receptor called endothelial protein C receptor. That's called EPCR. If you want a different mechanism, I'll draw separately. If you ask, this is the endothelium. So on the surface, you have a receptor called endothelial protein C receptor, and this is the one that is going to have the protein C locked with them. This is the endothelial cell. We can draw like this. So what happens is, whenever the thrombin is released, that is going to combine with another molecule synthesized by the endothelium, that is called thrombomodulin. Because this protein is moderated by the action of thrombin, that's why it's called thrombomodulin, and these two mix together, they form a complex, thrombin-thrombomodulin complex, and that is going to release the protein C in the activated form. So this is the activated protein C. This activated protein C is going to inhibit factor 5A, which means they're going to lyse the factor 5A. It's a protease. They're going to degrade factor 5A. And a very important cofactor for this step is, I told you, it's proteinase. So protein C and proteinase, work in conjunction to lyse the factor 5A, because this factor 5, I told you, is very important for the formation of factor 10. So this is the common pathway. So it blocks the common pathway step. So it's very important for formation of the factor 10, which is again very important for the formation of further thrombin. Clear? So it's like a negative feedback step. So this doesn't happen. So thrombin levels will decrease further. So thrombin itself inhibiting itself. This is a negative feedback system. So this is how anticoagulation is going to work. So there is one clotting mechanism is there, clotting disease is there, that's called factor V Leiden mutation. That's called FVL, factor V Leiden, Leiden, factor V Leiden mutation, which is otherwise referred to as something called activated protein C resistance. Activated protein C resistance. What do you mean by activated protein C resistance? That is nothing but this factor 5A will go for some mutation. This factor 5 will go for some mutation, which means it's a mutated factor 5 now, which will not be amenable to lysis by protein C. Protein C cannot now cut the factor 5 and inactivate the factor 5, which means factor 5 activated levels will become excess, and that will lead to a thrombophilia or excessive clotting disease called factor V Leiden mutation. In fact, factor V Leiden mutation is considered to be the most common inherited thrombophilia. Very important point. It's the most common inherited thrombophilia in the world by different studies. So this is the importance of protein C and proteinase. Why I told you so many things here is because your this thing is not only dependent on your vitamin K. Vitamin K is not only going to activate your 2, 7, 9, 10 clotting factors, but they are also going to activate through anticoagulant factors called protein C and proteinase. These are also vitamin K dependent, which means vitamin K reduces both clotting as well as anti-clotting factors. In the sense, like, their effect may be sometimes unpredictable and the dosing is something unreliable. Some people may not higher dose, some people may not lower dose. There is no standard dosing for warfarin. You have to keep shifting the dose. So many problems are there with warfarin. That is the reason currently the world is trying to prefer an agent called novel oral anticoagulants. A lot of advantages which we'll discuss later on, how this are going to work. Clear? So now, once having said all these things, we can now discuss about the heparins. Clear? Heparins, and you have fondaparinux also separately. We can put separately, even though they can be put under heparins, but let me put separately fondaparinux. Heparins has two types. One is called unfractionated heparin. Second one called low molecular weight heparin. Low molecular heparin itself has 3 different drugs. One is called enoxaparin, the famous Clexane what we use, brand name. So enoxaparin. Then you have something called dalteparin. I in certain areas do prefer dalteparin, but tinzaparin I never used. You have another drug called tinzaparin also. In what way each and everything is going to differ? In what way the action is going to be different? Because heparins and fondaparinux all are going to act through a common pathway called activation of antithrombin 3. But you have studied in the textbooks that heparins inhibit thrombin more than factor 10. For example, if you ask heparin will almost have similar action. Like factor 2 will be inhibited almost equivalent to that of thrombin. So unfractionated heparin is going to inhibit factor 2 almost equivalent to that of inhibition of factor 10. Clear? Both are almost similar. They are going to inhibit both factor 2 and factor 10. But low molecular heparin is going to inhibit factor 10 than factor 2. And at the same time, fondaparinux is going to inhibit factor 10A only, which means they are actually factor 10 inhibitors. Indirect factor 10 inhibitors only, fondaparinux. Indirect, not direct. Indirect factor 10 inhibitors. But how is this possible? How in the world is this possible if they are same drugs? But they are quite different in the structure. That is what is going to give a key to understanding. Let us assume this to be the heparin molecule. Heparin contains 2 important things. One is the active pentasaccharide molecule, and you have a huge side chain. You can call it as R. Maybe you can put R here. So this is a huge side chain. But whereas your low molecular heparin is also going to contain a active pentasaccharide molecule is also going to contain this active pentasaccharide molecule, but it's going to have a relatively very short R side chain. Clear? That is why the name came. It's a low molecular weight, truncated heparin molecule. It's a low molecular weight heparin. Then what is fondaparinux? Fondaparinux is something that is going to have only the active pentasaccharide molecule, because it is no side chains at all, no R chains, no side chains at all with this fondaparinux. So these structural differences are the ones that are going to give the differences in their properties also. For example, what are the differences in the properties you see? There are two molecules. One is, let us assume this is a thrombin molecule. So let me put this a thrombin. This is activated thrombin, that is 2A, and let us put this is 10A. Maybe a little different, 10A. So let us put this at 10A. So remember, thrombin has active catalytic sites. This is the one. This has active catalytic sites, but similar structure. This is the active catalytic site for thrombin. This is the active site for thrombin. And 10A molecule doesn't have any active sites like that. But remember, this heparin group of this pentasaccharide, which I told you, this pentasaccharide is the one that fits into the structure of both thrombin as well as 10A. This pentasaccharide is the one that is going to fit into the structure of both thrombin as well as factor 10. But it's the side chains that are very important. I told you, to cover up the active sites, of thrombin, you need these side chains. You need these side chains to cover. So let us assume this is the R side chain of your, like unfractionated heparin. They do cover up, like in a very well way. But if you ask me about the fondaparinux, let us duplicate the image again. What happens? So this is the active catalytic site of thrombin. So let us put this the active catalytic site. Now you can see what happens in your low molecular heparin. So if you take this the low molecular heparin, I told you it's going to have a short structure, which means it's going to cover only a limited amount of this active catalytic site. So which means their efficiency of blocking the thrombin is less compared to that of unfractionated heparin. Similarly, if you take a fondaparinux, let us take a fondaparinux similarly. If you take a fondaparinux, what is going to happen is, sorry for the delay, but still it's very important to understand. If you take a similarly a fondaparinux molecule, it's not going to have any side chains at all, which means it has no scaffolding. It is not going to block your factor 2A at all, which means unfractionated heparin has a good factor 2A inhibition, thrombin inhibition. Low molecular has a reduced factor, thrombin inhibition, 2A inhibition, whereas fondaparinux doesn't have any factor 2A inhibition at all, no thrombin inhibition. That's why these differences are there, I told you. But for inhibiting factor 10 I told you doesn't have any active catalytic sites like what you have for thrombin. Because of that, all the molecules what you see can inhibit easily your factor 10, because this R, whether it is present or not, doesn't matter here. You just need this active pentasaccharide molecule, whether it's short or whether it's long, doesn't matter. Only one thing you need for inhibiting this factor 10, that is this active pentasaccharide molecule. So which means the central active pentasaccharide molecule is enough to inhibit this factor 10. That is why I told put X here. I put X here. To inhibit factor 10, you just need this active pentasaccharide. The side chains are the ones that are going to determine the ability of thrombin inhibition. Since the side chains is not there in fondaparinux at all, they cannot inhibit this thrombin as well. So it is all about the scaffolding. So this is how your system works, and this is how your differences in the properties of the heparin is there. At the same time, this side chain also determines a very important function. The pharmacokinetics and the side effects are also determined by this side chains only. It's not the pentasaccharide that is actively inhibiting the factor 10. That is not the one that determines the properties, pharmacokinetics and pharmacodynamic property of the heparin. It's the side chains that determine the pharmacokinetic. For example, the side chain is the one that is very important for one disease called heparin-induced thrombocytopenia. Since the side chains are larger, risk of hit is very high with, not very high, it's a little bit high with your traditional unfractionated heparin. Since the side chains are smaller, risk of hit is still there, but a little bit lesser compared to that of unfractionated heparin. Since there are no side chains here, the risk of hit is very high. There is no risk of hit at all in case of a fondaparinux. So fondaparinux has literally no risk of heparin-induced thrombocytopenia, whereas low molecular weight has reduced risk, but unfractionated heparin has a standard risk of developing heparin-induced thrombocytopenia. Similarly, whether it is cleared by kidney or whether it is cleared by liver also depends on the side chain only. The side chains make the property of heparin to believe that this are going to be cleared by the reticular endothelial system. The side chains are the ones tell why I wrote R is not only because of that. You can also tell the heparins, unfractionated heparin is going to be cleared by RES. But the moment your side chain length keeps reducing, your clearance will be more dependent on the kidney. That is also one important factor is there. And this is also going to get translated into your monitoring techniques also, because I told you heparins are going to, unfractionated heparin is going to inhibit both factor 10. You can write here. Unfractionated heparin is going to inhibit factor 10 also. At the same time, unfractionated heparin is going to, here we can write 10 also, and it's going to inhibit factor 2 also, which means it's going to inhibit both the common pathway and the terminal pathway. But remember, your low molecular heparin is going to predominantly inhibit factor 10 only, and factor 2 is not at all inhibited. So remember this 2, 7, 9, 10. So this 2, 7, 9, 10 is this extrinsic pathway is actually monitored by, anyway we are going to discuss in later on. The extrinsic pathway is typically monitored by prothrombin time, and your intrinsic pathway is typically monitored by, you can write intrinsic pathway here. Your intrinsic pathway is typically monitored by activated partial thromboplastin time. Clear? So I can write what are the monitoring agents here. So anyway I am going to discuss in detail again. Your extrinsic pathway will be is going to monitor, your prothrombin time is going to monitor two things, that is the extrinsic pathway and the common pathway. Because like 2, 7, 9, 10, that's very important. Similarly, the intrinsic pathway and the common pathway will be monitored by an entity called activated partial thromboplastin time, APTT, which means they're going to monitor both intrinsic pathway as well as the common pathway. Remember, unfractionated heparin, your APTT measurements will be very reliable. For measuring the activity of unfractionated heparin, you can use APTT. APTT is very reliable actually for monitoring the effect of unfractionated heparin. But remember, APTT becomes unreliable for monitoring the fondaparinux and low molecular weight heparin activity. It's not reliable. But you can see whenever you use heparin, now the shift is towards more of a low molecular heparin, not your unfractionated heparin. That's why we are currently more preferring the low molecular heparin. Only in very selected circumstances we are going to prefer unfractionated heparin, like kidney failure, severe obesity. In those conditions, we can prefer unfractionated heparin. Apart from that, low molecular heparin is the one that is preferred for almost every single reason in the world, if you want to use an heparin. Fondaparinux for again selected certain reasons. Fine. So your APTT measurements is not going to be that reliable for low molecular heparin and fondaparinux. So that is the reason why we have devised a new technique to measure the heparin activity, because something should be common for unfractionated heparin, fondaparinux, low molecular heparin, something you should use which can be used as a commonality for all the three actions. So that is the reason why the common thing that it blocks, all the three heparins, unfractionated, low molecular heparin as well as fondaparinux blocks is the factor 10, because all those have the common pentasaccharide unit that is going to block the factor 10 definitely for sure. Thrombin inhibition is variable among all these three, but factor 10 inhibition is definitely solid and definitely there for all these three things. That is the reason why all the heparins are currently universalized, and we are going to measure their activity by a test called anti-factor 10A levels. We are going to measure through a very, very important a monitoring mechanism called monitoring test called anti-factor 10A levels. This you can use for unfractionated heparin also. This you can use for low molecular heparin also. This you can use for fondaparinux also. This could be a very important question for the future. anti-factor 10A levels. Very important. Remember, unfractionated heparin, if you want to use APTT, it will be reliable only for unfractionated heparin. But if you use anti-factor 10A levels, it can be useful for all the 3 heparins. There is no doubt in it. Clear now? So these are the mechanisms of your heparin action. Similarly, your antidotes. What is the antidote? Protamine sulfate. Protamine sulfate also is dependent on the side chains only. They are going to bind with the side chains only, and that is how they inhibit the heparin as a whole. They form a scaffolding within the heparin itself so that they block completely the heparin action. So that is the reason protamine sulfate is very, very effective for unfractionated heparin, because they have a longer side chain. Whereas for low molecular heparin, this protamine sulfate will be to an extent effective, but not that much, because side chains are truncated small here. To an extent it will be effective, but not like what is effective for your unfractionated heparin. For fondaparin X, your protamine sulfate will not be effective at all. Clear? Fondaparin X, will not be effective for, your protamine sulfate will not be effective for, effective as an antidote for fondaparin X by any means. That is very important. This is only a preliminary diagram, and remember why I am telling you this is because here I told you like heparins are directly inhibiting, but remember heparins do not directly inhibit your clotting factors. In between, all these are mediated through a very important factor called antithrombin 3, which I have drawn at the last just to make you understand. That's it. So here antithrombin 3 is going to be in between, and it is very, very important. So all these actions are mediated through antithrombin 3. Heparin cannot bind with these factors directly. First understand. Even though initially I told that the heparins are binding directly, heparins are not going to bind with these compounds directly in the first place. They are going to bind to all these factors, 2A as well as 10A, through the antithrombin 3 molecule only, by forming a structural change within the antithrombin 3. And the side chains are the ones that form the scaffold that block the active site of 2A with the help of antithrombin 3. But without antithrombin 3, like initially what I showed in the diagram, it's impossible to combine with the clotting factors. Very, very important point. So that is why heparins are thought to be something called indirect. Now hope I think you get all the important idea about how these heparins are acting. Now let us go on to the table, our famous table. So where it will tell anticoagulant. What is anticoagulant? Remember T half of the anticoagulant, and what will be the mechanism of action, then where will be the metabolism, and what will be the laboratory parameters that you're going to use, and in overdose what you're going to use the treatment as an antidote. Number 1, let us go for the unfractionated heparin. Half-life is very short, 60 to 90 minutes. Again, because the side chain is excess, they will be not that much stable compared to other compounds. Because of the big side chain, stability is reduced. So they will be destroyed very fast. Mechanism of action is through activation of antithrombin 3. Antithrombin 3 activation. But remember, factor 2A inhibition is equal to that of factor 10A inhibition because of the side chains that form the scaffold. Metabolism is through reticular endothelial system. Laboratory wise, they are going to increase the PTT. So through the partial thromboplastin time only, you are going to find out the activity of unfractionated heparin. But remember, you also have currently called anti-factor 10A activity that can also be used. Currently, this is what is preferred. Treatment of overdose, definitely protamine sulfate, very important. How much you will give? 1 milligram neutralizes 100 units of unfractionated heparin. Maximum dose, how much protamine sulfate you can give is 50 milligram. Remember, if the last dose of unfractionated heparin is way long ago, then the dose will be less, like 0.5 milligram also can be given. But generally 1 milligram is the dose that is needed for the for neutralize 100 units of unfractionated heparin. If you given unfractionated heparin before very long way ago, then the dose of protamine sulfate may be even less. But anyway, so this is the dose. Standard dose 1 milligram neutralizes 100 units of unfractionated heparin. Then you have low molecular heparin. Low molecular heparin is a little bit longer half-life, 2 to 7 hours, very important. T half is increased because the side chain is reduced, stability of the molecule is high. Then it also works by activation of antithrombin 3, but remember factor 10A inhibition is more than thrombin inhibition, factor 2A inhibition. Metabolism by the kidney, very, very important point. That is reason in kidney failure, you have to reduce the dose. But whereas in unfractionated heparin, in kidney failure, you need not reduce the dose. Very important point. Clear? In kidney failure, you need not reduce the dose. Whereas in kidney failure, low molecular heparin dose has to be reduced because it's cleared renally. And remember again, monitoring best is anti-factor 10A activity. You cannot use partial thrombolysis, not reliable. Again, protamine sulfate can be used by approximately, remember, efficacy is only 60% of what it works for your unfractionated heparin. But remember, only 60% efficacy compared to unfractionated heparin, but not definite, not that much is going to work. For enoxaparin, you can give 1 milligram per milligram of enoxaparin, 1 milligram protamine sulfate per milligram of enoxaparin, which means it's equal to equal. 1 milligram is equal to 1 milligram. Similarly, for dalteparin and tinzaparin, tinzaparin doesn't come in milligram. Only enoxaparin comes in milligram. Those who are practicing, you will definitely know. Standard dose of, for example, enoxaparin in thrombotic conditions, maybe will give 60 milligram BD subcutaneously. So which means enoxaparin dose will be calculated in milligram. So 1 milligram equal to 1 milligram. 1 milligram protamine sulfate neutralizes 1 milligram of enoxaparin approximately. For dalteparin and tinzaparin, we give in units actually, not in milligram. So for example, 1 milligram neutralizes 100 units of 1 milligram protamine sulfate neutralizes 100 units of dalteparin or tinzaparin, like how you saw in unfractionated heparin. This is also very important to understand. Remember, low molecular weight dose has to be reduced in kidney failure. Very, very important point, which we'll discuss in detail later on in the subsequent sections when we are going to discuss. Then you have fondaparinux. Fondaparinux half-life is 15 to 17 hours. It's even more because there is no side chain at all. Stability is too high, so they are going to circulate for a longer time. Very, very high, and the dose needed is also very, very less for fondaparinux. And again, it works by activation of antithrombin 3. It doesn't have side chain, cannot form scaffold around factor 2A, that is thrombin. So it is a pure factor 10A inhibitor. That's the reason. And again, it's eliminated through the kidney. Again, you need a lesser dose in the kidney failure. Again, measured through anti-factor 10A activity. But you do not have any antidote for this. Probably there is an antidote called andexanet alpha, which is used for factor 10A inhibitors. But probably we don't know the role. Probably we think it's effective, and some trials are telling it's effective, but nothing is approved. And probably, but we don't have any antidote. But please do remember, protamine sulfate will not work here because there are no side chains to act upon. It will not work as an antidote here. And andexanet alpha probably to an extent. But one more drug is there which I'll tell you probably, and again another drug called siraparantag is there. This also may have a probable use, but we don't know. These two might work for fondaparinux, but very difficult to reverse. We don't have any proper data for that. So these are the indirect drugs. Direct drugs, one of the important thing is bivalirudin, and second one is argatroban, because these are direct inhibitors of clotting factors. Direct inhibitors of typically factor 2, thrombin inhibitors. These are direct factor thrombin inhibitors, but are parenterally given, bivalirudin. We discussed the classification already. Half-life of bivalirudin is given IV, so typically it is given only 30 minutes is the half-life approximately, and it's a direct D factor 2A inhibitor. That's a direct thrombin inhibitor. Metabolism happens through the kidney once again, and again probably labs is elevated PTT. That's the only thing you can find it out because it's a factor inhibitor, but apart from that, we don't have any other effect. Then typically there is no antidote for this, only dialysis can be done because it's, amenable to dialysis. Then you have argatroban. Again, half-life, it's a direct factor 2A inhibitor, given by parenteral route. It's not indirect like heparin. And again, half-life is only 45 minutes. And again, it's a direct factor 2A inhibitor, that is direct thrombin inhibitor. Metabolism is through the liver, and monitored maybe through elevated, but there is no monitoring really. And again, the only way to treat an overdose is dialysis. There is no other option. So these are things you can do. And next you have oral warfarin. Warfarin is there, and azenocomarol also. Warfarin action is 36 hours. You remember, any anticoagulant if you take, this is the maximum duration of action. 36 hours warfarin, and it's an indirect acting drug. It's not a direct acting drug, which means it's going to reduce the gamma carboxylation of clotting factors 2, 7, 9 and 10 indirectly through vitamin K mechanism, not directly. So metabolism again in the liver, no brainer, everything happens in the liver, and again increase PT-INR. Increase PT-INR, very important, increase PT-INR. This is, INR is the, way we monitor the warfarin activity, because the target INR is 2 to 3, because this drug has a very narrow therapeutic range, warfarin. So we have to keep the INR 2 to 3, or in very rare instances, we keep 2.5 to 3.5 or 3 to 4. Very rare instances. But general INR target is around 2 to 3. That's what we keep in warfarin. And next thing you have to do in overdose. What you have to do in overdose? In overdose depends on what is the bleeding, whether there is no bleeding or whether there is bleeding. If there is no bleeding, depending on the INR. If INR is less than 9 or INR is more than 9. No bleeding, only asymptomatic elevation of INR. I told you target INR is 2 to 3, but if it's elevated asymptomatically, if it's less than 9, just skip 1 or 2 doses and recheck INR. Skip 1 to 2 doses, that's all. Skip 1 to 2 doses of warfarin and just recheck INR. That is more than enough. Remember, they are telling you can give a oral vitamin K, but we don't know the benefit of this. But anyway, or just keep 1 to 2 doses, and because there's no bleeding, there's no urgency, just keep 1 to 2 doses, it's enough. INR will fall down and then you can retitrate the warfarin. That's why warfarin is dangerous. It doesn't have a standard dose. You can keep changing the dose, and you have to keep the INR in 2 to 3, that's it. Very difficult, very, very difficult. When it will go low, when it will go high, we have no idea. Then INR more than 9, definitely you have to skip warfarin for some few doses, skip 1 to 2 doses, plus at the same time, definitely in this condition, you have to give oral vitamin K. Oral vitamin K, typically we give a 2.5 milligram dose. This is for sure you have to give, because INR is very, very high, more than 9. So it is something anytime the patient might bleed. So in a bleeding patient, what you will do? If the patient is bleeding supposedly, first obviously you have to stop all form of warfarin, plus immediately give vitamin K 10 milligram IV dose. Immediately you have to give an IV vitamin K, which is a very important antidote. At the same time, you have to use either an FFP. You will give around 2 to 4 units every 6 to 8 hours. That's the standard dose I follow, 2 to 4 units every 8 hourly. That's what I do. So FFP you have to give. This is a poor man's, clotting factor replacing agent. But if you have in your hospital, that is called a 4-complex PCC. That's called 4-complex prothrombin complex concentrate. It's called prothrombin complex concentrate. This is the one that is going to have the prothrombin group of clotting factors. That is 2, 7, 9, 10. That's called 4-complex PCC. This is very expensive, but if it's there, this becomes a very important treatment, 4-complex PCC. But IV vitamin K, if you don't have this, then alternative will be FFP. It also contains a good amount of clotting factors. It raises the clotting factor, any clotting factor level by 30%, FFP. So it's okay, you can use FFP. Fresh frozen plasma. This is how you treat a warfarin-induced overdose. So now next you have direct drugs. Direct drugs, you have something called dabigatran. Dabigatran, you know very well. Half-life of dabigatran is going to be around 12 hours. It's 1/3 of warfarin. Again, it's a direct drug. Direct means it's a direct factor, 2A inhibitor. That's a thrombin inhibitor. Dabigatran is a direct thrombin inhibitor. And metabolism is through the kidney, and maybe have elevated PDT, but this is not, I'm telling it's elevated PDT is there, but this we don't use for monitoring purpose. Very important. Generally, NOACs are not monitored. And finally, antidote. You have a monoclonal antibody called idarucizumab. Idarucizumab, you can remember here, it is an inhibitor of dabigatran. Clear not? So that's why it's called idarucizumab. It's a monoclonal antibody that binds the dabigatran drug directly. But it's very expensive. Then you have factor Xa inhibitors like rivaroxaban. You know very well, this is a factor Xa inhibitor. Apixaban, again it's a factor Xa inhibitor. Apixaban. Then you have edoxaban. This is also a factor Xa inhibitor. Half-life approximately varies from 8 to 12 hours, but generally around 10 hours. And it's a direct factor Xa inhibitor, direct drug. Then again it is metabolized by kidney and liver both, but predominantly by the kidney. And again probably increase PT, anti-factor Xa level, all these things you can use, but typically again I'm telling you, these NOACs are something not monitored, even though that is given in the textbooks, but it's not monitored. Antidote, one drug that is approved as an antidote, that's called andexanet alpha. Andexanet, you can remember 10E is here also, that's called andexanet alpha. Very important drug. This serves as a decoy receptor. Decoy receptor in the sense like, for example, this NOAC, for example, if you take this NOAC drugs, these are going to bind with the factor 10A molecule. Clear? Actually, this andexanet molecule also behaves like, it is like factor 10A. It is similar in structure to factor 10A, similar structure to that of factor 10A, which means it makes the NOAC bind with andexanet alpha, which means they effectively reduce the levels of free NOACs, which can block the factor 10A. So that's why this andexanet alpha works. It's like a decoy receptor for NOAC. This factor 10A inhibitors. That's how it works. So, anyways, only one important thing about edoxaban I need to tell. This edoxaban actually is contraindicated in patients with EGFR more than 95 ml per minute. In a normal in the sense like in a patient who is having a high GFR, you cannot give edoxaban, because among all these three drugs, if you ask me, edoxaban is the one that is maximally renally cleared. Maximal renal clearance is for edoxaban only, which means in a patient who is having a higher GFR than normal, you might actually experience a faster clearance of edoxaban, which means the anticoagulant activity of edoxaban may not be proper in a patient who is having a higher GFR. So that is the reason why you cannot give in a patient with a higher GFR, not a lower GFR. So which means its increased risk of thrombosis there in these patients. That is the reason you don't give. This is something which is, I felt like might be asked in exam, because it's something very different from what you think. Low GFR many drugs are contraindicated, but this is the drug that's indicated high GFR. That's why edoxaban is very important to understand about that. So with this, I have told you almost all of the anticoagulants in a nutshell. In this, you can see this unfractionated heparin, low molecular heparin, fondaparin X are indirect and parenteral. You know that these are indirect and parenteral drugs. And your bivalirudin and argatroban are direct and parenteral drugs. Direct and parenteral drugs, which I saw seen already. And warfarin is the old oral indirect drugs. And this dabigatran all come under novel oral anticoagulants, which means these are oral and direct drugs. Dabigatran, rivaroxaban, apixaban, edoxaban, 4 most important NOACs. So these are things that you have to understand. So a lot of things are there. So when you, my concern will be on this anti-factor 10A levels only, because currently we are using low molecular heparin only in a lot of clinical scenarios. So what are the importance of this anti-factor 10A activity? We have something called anti-factor 10A activity. So when will you measure this anti-factor 10A activity? Let us see. So first, you know the indications of anti-factor. Not in all patients we test anti-factor 10A. There are certain indications. Number 1, you have creatinine clearance less than 30, which means in deranged kidney function. Definitely, because I told you this low molecular heparin and fondaparin are cleared kidney wise. So for low molecular heparin, when the kidney function is deranged, it's better to titrate the levels with anti-factor 10A activity. Then in very elderly patients, because heparin is totally dependent on body weight also. Very elderly patients, like in more than 85 years of age, you need this. Then extremes of body weight, especially if it's less than 40 kilogram or more than 140. Again, I told you it's dependent on body weight also. So that is the reason extremes of body weight, severe obesity, again you can use anti-factor 10A to monitor the, typically I'm talking about low molecular heparin. So here is where you use this anti-factor 10A activity. Then in pregnancy, again the kinetics are very different in pregnancy, especially those who have pregnant patients with mechanical valves. Those who had a MS, mild stenosis previously and had a mechanical valve now, you can go for this anti-factor 10A activity measurements. So for unfractionated heparin, whether you can use or not, yes, you can still use, no problem. But APTT itself is better for unfractionated heparin. But still, if you want to use, this is a standardized one. You can use anti-factor 10A for unfractionated. What is the target for low molecular heparin? Target is for, if you are using heparin for a therapeutic purpose, or if you are using low molecular heparin for a prophylactic purpose. For a therapeutic purpose, if you are using low molecular heparin, your target must be 0.5 to 1.2 international units per ml. If you are using for a prophylactic purpose, then it will be 0.2 to 0.5 international units per ml. So this will be very important for exams, especially therapeutic, they might ask in exam. This is the target anti-factor 10A levels that you should maintain. I mean, this is what we do currently nowadays, especially in these patients. That is the reason why if you don't have this anti-factor 10A activity, if you don't have this anti-factor 10A activity in your system, in your hospital, if the patient is having any one of this, pregnant patient, mechanical heart valves, extremes of body weight, very elderly patient, creatinine clearance less than 40, severe obesity, that is extremes of body weight. In these conditions, prefer unfractionated heparin. Simple, because they're not cleared by kidney and they don't have any of these things to worry about. If you have all this, any of these problems like creatinine clearance less than 30, severe extremes of body weights, very, very old patients, pregnant patients with mechanical valves, if you have anti-factor 10A activity in your hospital and if a patient is affordable, please go for low molecular heparin and anti-factor 10A activity measurement itself. But if you don't have anti-factor 10A activity measurement in your hospital, please avoid low molecular heparin and better to go for unfractionated heparin itself, because unfractionated heparin need not be adjusted, dose adjusted in these conditions. Especially in exam question is unfractionated heparin need not be adjusted for body weight, need not be adjusted for your kidney function also. Even the kidney function is deranged very badly, your unfractionated heparin dose is going to be the same. Only low molecular heparin will be changing. Okay, clear? So these are the important things that you have to know. And what is the timing to measure this this anti-factor 10A levels after you have given the low molecular heparin? It is 4 hours after the recent dose, after the last dose. That is the time where you have to measure the anti-factor 10A. Because I am doing this regularly, very regularly we are doing this. That is the reason it's very important to know. It could be not an update. It's been there for the last 1 decade almost, anti-factor 10A measurement, but still, since it's not been asked in exams, I'm concentrating a little bit more. So 4 hours after the last dose of low molecular heparin, you can measure the anti-10A activity. And we told you antidotes. 3 antidotes are very important. Dabigatran, important antidote is idarucizumab. For all NOACs, idarucizumab. For all NOACs, because for all NOACs we have antidotes now. Then for factor 10A inhibitors, all the oral factor 10A inhibitors, we have andexanet alpha. Andexanet alpha. There is a new investigational antidote called siraparantag. Which actually interacts with the anticoagulants through the hydrogen bonds, where it's going to inhibit NOACs also, it's going to inhibit heparins also. This can be widely used, that's what they're telling, because it can bind with many anticoagulants, not only on one particular, this is a broad spectrum, that's what being investigated, but it's not yet approved for any particular action, but it's very upcoming one, siraparantag, which might be approved in the next 8 or 9 months probably, but anyways, we have no idea. So this could be one of the very broad spectrum antidote that is available for NOACs as well as for heparin group as a whole, because they interact with anticoagulants not through by pocket lock and key method, they interact through your hydrogen bonds and your charge interactions. That's how they work. So clear? So these are the things that are very important to understand. Now let us see the differences between NOACs and warfarin. What are the difference between normal oral anticoagulants and warfarin? NOACs are more predictable in their action. That is why the chances of major bleeds are a bit less with NOACs. But whereas warfarin is unpredictable in its action. It cannot be predicted because a lot of interactions that which we'll discuss. That is the reason why warfarin has a little higher risk of major bleeds. One small nick you need to know that warfarin has a low risk of GA bleeds though. Even though the major bleeds risk is very high with warfarin, actually the GA bleeds risk is actually low with warfarin. Since they are having predictable action, they are more of a fixed dose as well. But whereas warfarin, since it's unpredictable in its action, the dose is very labile. It's not fixed. Anyone who's taking warfarin, you will be seeing them, and because of the INR monitoring, based on the INR values, they'll keep on shifting the warfarin dose. It's not a standard dose at all. And that means NOACs need no monitoring. No monitoring, whereas warfarin needs very, very regular monitoring with INR, international normalized ratio, because being a drug with a very narrow therapeutic index, it needs monitoring.
And this is one reason why warfarin may have a little bit more complaints compared to that of NOACs, because since they need monitoring, it makes the patient come to the hospital again and again, which makes the patient more complaint to the doctor as well. Since they need no monitoring, they might be associated with a bit of poor compliance because the patient may take these drugs for granted and the patient may not know the seriousness of taking these drugs and they might discontinue the drugs or skip the drugs. Warfarin definitely INR will reflect, so the patient itself will get little panicky. So that's the idea. Apart from that, drug and food interactions. Drug and food interactions are very, very less as far as NOCs are concerned, whereas drug and food interactions are very, very high in case of warfarin. So even a simple grapefruit juice can alter the kinetics of warfarin and you might even lower the levels of warfarin. So be very careful. In renal failure, warfarin is absolutely safe. Absolutely safe, but they do have some renal effects. Renal effects are there, which means certain NOACs need dose adjustments in renal failure. Dose adjustments in renal failure. Clear? So these are some of the differences that you have to know between NOACs and warfarin. One of the most important difference that you have to know is on the bridging. So I'm going to talk about bridging. So what do you mean by bridging? A patient is taking an oral anticoagulant like NOACs or a warfarin, and there is a need to stop this oral anticoagulant. And the moment when you stop the oral anticoagulant, during that time, this oral anticoagulants will be replaced with a parenteral anticoagulant. Replaced with parenteral anticoagulant. And after some time, when the condition resolves, this parenteral anticoagulant will be shifted back to the oral anticoagulant. So this period of parenteral anticoagulation, at the time when you don't want to use or when you are not able to use oral anticoagulants, when you are using parenteral anticoagulant instead of oral anticoagulant during that time is what we refer to as bridging. This is called a bridging parenteral anticoagulation. Very common bridging parenteral anticoagulation is heparin, and very, very commonly it will be a low molecular weight heparin. Clear? This is the usual bridging anticoagulation. When oral cannot be used or oral is not used, that time you will use heparin as a bridging anticoagulation. So whether you need bridging or not, again depends. It's a big topic. Warfarin definitely needs bridging. Usually warfarin will start along with heparin, either a low molecular weight or unfractionated heparin. You have to typically wait for 3 to 5 days because warfarin action is very slow and it takes 3 to 5 days to complete its action, depending on the half-life of the clotting factors. So how long you have to wait? Once the INR reaches the target, in most cases the target is 2 to 3 and it has to maintain at a stable point for over at least 24 hours, which might take 3 to 5 days easily, even 6-7 days. Till that time you have to continue heparin, and once this INR reaches 2 to 3 and you know it's stable for at least 24 hours, you can discontinue heparin, whatever heparin you are using, and continue with warfarin only. After this, if you give heparin along with warfarin, the risk of bleeding will be very high because warfarin also start exerting its action. Heparin also will be there acting separately with a different mechanism, and you're going to increase the risk of bleeding. That's it. So and continue warfarin only in this case. So this is one way. So where you are doing heparin bridging. Whether NOACs need heparin bridging or not, do they need bridging? Answer is no. Especially if you are using for prophylactic purposes. For prophylaxis of DVT pulmonary embolism, if you are using NOACs, typically they don't need any bridging at all, and they can be used as sole anticoagulants. You don't need any bridging, especially if you are using for prophylaxis of a venous thromboembolism like DVT or a pulmonary embolism. But when you are using for therapeutic anticoagulation, when you're using for therapeutic, which means you have a proven case of a pulmonary embolus or a venous thromboembolism or any other thrombotic condition, it's when you're using for proven thrombosis as a therapeutic entity, at that time it is variable. Why I told variable? It depends on what NOAC you are using. For example, there are 4 NOACs, you know. One is called dabigatran, we have seen some time back only. Second one is edoxaban. Third one is rivaroxaban, and third one is apixaban. Clear? So why I've written in this order is because these two anticoagulants, NOACs, dabigatran and edoxaban, actually need initial heparin bridging. Initial heparin bridging, in the sense we don't add this NOACs with heparin, we use only heparin initially. Heparin only initially without NOACs. At least for 5 to 14 days you have to wait. Clear? Depending on the condition. Typically minimum we wait for 5 days at least. We wait for 5 days, and after that, after this period of initial bridging heparin anticoagulation, you convert them to sole NOAC if you are using dabigatran and edoxaban. So this initial bridging is mandatory if you are using for therapeutic purposes, for dabigatran and edoxaban only. But if you are using rivaroxaban and apixaban, initial heparin is only optional. Optional initial bridging, which means you don't need initial bridging. If you don't want to do any initial bridging, there is no need of initial bridging with heparin. And you can start them as a sole anticoagulant from the beginning itself. Sole NOAC from the beginning itself. There is no need for initial heparin anticoagulation, which means this rivaroxaban and apixaban can be used as a sole anticoagulant from the beginning itself. So for prophylaxis, no need of bridging at all. For therapeutic anticoagulation, the bridging is variable. If you are using edoxaban or dabigatran, initial bridging is recommended for at least 5 to 14 days. Initial bridging is usually with heparin. Later on, you shift to NOACs, that is dabigatran or edoxaban. But in case of a rivaroxaban or apixaban, you don't need this initial bridging anticoagulation, which means it's only optional. If you want, you can use, otherwise you do not use. I mean, initially from the beginning itself, you can use rivaroxaban or apixaban as a sole anticoagulant. So that's the idea. So this is variable, especially if you are doing a therapeutic anticoagulation. Clear? This is a very, very important point, very crucial to understand. At the same time, I told you this edoxaban is the only drug that is contraindicated in EGFR more than 95. This is a very important point for exam to know. Edoxaban is the only drug that is actually contraindicating EGFR more than that 95 because it is significantly cleared by the kidney. So more clearance in more GFR means the levels of the drug will be less, so that increased risk of thrombosis will be there. That is the reason. So this is again very important to understand. And the brand names, if you want to know, very common brand names what we use for dabigatran is Pradaxa and Dabigo, and rivaroxaban is Xarelto, and apixaban is Eliquis. This is not needed for you. Obviously, I'm not trying to promote any brand. These are the original brands that came in the market initially. So still we use them. So that's why I told you this as well. So these are some of the important NOACs, novel oral anticoagulants, because the entire world is getting shifted towards NOACs now. NOACs are now approved for DVT and pulmonary embolism, for prophylaxis as well as treatment. This has become the most important treatment right now. Clear? Then second area where you can use is in atrial fibrillation, but this atrial fibrillation should be non-valvular. For a valvular AF, still NOACs are not yet approved. Clear? Especially for stroke prevention, for prophylaxis of stroke prevention, ischemic stroke prevention due to embolus, you can use NOACs, but this should be a non-valvular AF. Very important. But on the other hand, warfarin is approved for use in DVT and PE, but for both prophylaxis as well as treatment. At the same time, for AF, it's been approved for both valvular as well as non-valvular AF. Clear? Valvular as well as non-valvular AF, both it can be used. Even for CVT, it can be used. For this cortical venous thrombosis, your NOACs are not yet received any approval. But for warfarin, even you can use it in a CVT patient, cortical venous thrombosis. And one more area where we prefer warfarin ahead of NOAC. Ideally, NOAC is the preferred choice right now for many conditions, especially for DVT-PE. But even in a DVT-PE, where you will use this warfarin ahead of a NOAC, especially in a patient with APLA syndrome. APLA syndrome with the venous thrombosis, we use warfarin ahead of a NOAC because it's been proven that these NOACs are inferior to warfarin in a patient who is having a venous thrombosis and a APLA syndrome, antiphospholipid antibody syndrome. So in those circumstances, warfarin is the one that is preferred. Clear? Apart from that, both NOACs and warfarin are safe in heparin-induced thrombocytopenia. It's the next topic which we're going to discuss. It's safe in both heparin-induced NOACs and warfarin are both safe in heparin-induced thrombocytopenia. So nothing to worry. So I can write here that fact that NOACs are preferred in DVT and pulmonary embolism in both treatment as well as prophylaxis after orthopedic surgeries. For both these conditions, you can use NOACs. But only one big exception will be APLA syndrome, where warfarin is preferred. Warfarin is considered to be superior in these cases. Warfarin is superior. This is very, very true, especially if the patient is triple positive. The patient is triple positive, which means all the three antibodies, APLA antibodies are positive, anti-cardiolipin, anti-beta-2 glycoprotein 1, and lupus anticoagulant. If all these three things are positive, unequivocally, your warfarin is going to be superior compared to NOACs. And typically, NOACs can be used only in non-valvular AF. I told you already. Whereas warfarin can be used in valvular as well as non-valvular AF. There is no contraindication. At the same time, they are also approved for DVT and pulmonary embolism, but less preferred except in the case of APLA. And remember, for CVT, only warfarin is approved as of now. NOACs are not yet studied for CVT, cortical venous thrombosis. Clear? So see, these are some of the major differences between heparin and warfarin. Clear? So next thing what we have to know is what are the warfarin interactions. That's what you have to know. What are the things that interact with warfarin? What are the things that increase warfarin action? And what are the things that reduce warfarin action? So a lot of drug interactions. The only important things, there are more than 150 drugs that are said to interact with warfarin, but we are going to see only very limited drugs. So first, I can tell drugs that increase the effect of warfarin by reduced binding to albumin. If the binding to albumin is reduced, free warfarin levels will increase. Because of that, the action will be potentiated. So what are those drugs? One is sulfonamides and probably valproate, but most important is the sulfonamides. If you know this is more than enough. Second group of drugs which inhibit cytochrome enzymes so that they can potentiate the warfarin action and increase the levels of warfarin. What are those drugs? Amiodarone, diltiazem, because these are cardiac drugs, so patient might be taking, especially when the patient is having a AF or a heart failure and a clot in the left atrium and patient is taking warfarin, means many patients will be taking diltiazem also. You have to be very careful about this. Amiodarone, diltiazem, propranolol, and lot of antibiotics like ciprofloxacin, erythromycin, fluconazole, or you can remember simply in the classes like quinolones, macrolides, and azole antifungals. So these are very important drugs. Alcohol, phenytoin, quinidin, allopurinol, tricyclic antidepressants, metronidazole, and sulfonamides. So these are some of the important drugs, of which, if you ask me, sir, this much I cannot remember, tell me only the few important drugs. I can tell amiodarone, diltiazem, ciprofloxacin, erythromycin, and fluconazole, and probably a metronidazole. So these are the important drugs. Especially if you remember these 5 drugs, that's more than enough. These are the very regular questions in exams. And third way, you can do this by alteration of hepatic receptor, altered hepatic receptors for warfarin. So there are hepatic receptors for warfarin, you know that's an enzyme. If some drug alters this hepatic receptor, what are the drugs that can alter the hepatic receptors? Thyroxine and quinidin. They can alter the hepatic receptors. And finally, those that decrease the vitamin K synthesis. What are the agents that reduce the vitamin K? Especially antibiotic therapy. Antibiotic therapy with broad spectrum we have discussed this already, that might reduce because your gut bacteria is important for producing vitamin K. So giving a broad spectrum antibiotics can create a problem in this gut bacteria that is synthesizing vitamin K, so that you might result in low vitamin K, which might actually potentiate the warfarin action, because low vitamin K have low synthesis of vitamin K dependent clotting factors, which can be potentiated by giving warfarin, because that inhibits the vitamin K as well. So addition and synergistic effect. It can happen with high dose of salicylates. Nowadays we don't encounter high dose of salicylates and certain cephalosporin drugs, not all, certain few cephalosporin drugs. But most important, clinically relevant here is this antibiotics, especially using broad spectrum antibiotics may potentiate warfarin action. And similarly, liver disease. Obviously, in liver disease, there will be reduced synthesis of vitamin K dependent clotting factors. Coupling with warfarin effect, it becomes synergistic and additional. And reduced absorption of vitamin K. Reduced absorption of vitamin K may happen in a patient who is having malabsorption, typically fat malabsorption, especially in a pancreatic disease or a small bowel disease. In those conditions, you might get reduced absorption of vitamin K. Or if the patient is having laxative abuse for a long time. So in this condition also, you might have a reduced absorption of vitamin K. So in this, the most clinically relevant is malabsorption, liver disease, and broad spectrum antibiotic use. Please do not forget this. These three are very, very important, that can in themselves cause vitamin K deficiency. At the same time, if the patient is on warfarin, that they're going to potentiate the action of warfarin like anything. So these are the things that potentiate the warfarin action. What are the things that reduce the warfarin action? Things that reduce the warfarin action are the ones that activate the cytochrome enzymes, so that they can accelerate the metabolism of warfarin, so that they reduce the level, so that they reduce the effect of warfarin. Drugs that cause this is barbiturates, good enzyme inducers, rifampicin, and other drugs like ribavirin. And you might get reduced action with enhanced synthesis of clotting factors. Whenever these 2, 7, 9, 10 clotting factors are synthesized more than necessary, especially happens when a patient is taking a oral contraceptive pill. Our third point, it can happen in a hereditary resistance to oral anticoagulants. There is an entity called hereditary resistance to oral anticoagulants. And finally, pregnancy. Again, because of increased synthesis of clotting factors. Pregnancy itself is a prothrombotic state. So these are the reasons where you can get reduced efficacy of warfarin that is administered therapeutically. So now we have seen what are the differences between NOACs and your standard warfarin, and what you mean by bridging process, and when will you use bridging and when you don't use bridging, and what are the advantages as well as resistance of warfarin, and what are the drug effects of warfarin that you are seeing. And the final disease, as far as the anticoagulants is concerned, you have to know about something called HIT, that's called heparin-induced thrombocytopenia. Right? We are discussing a lot of things about HIT. So what happens in this heparin-induced thrombocytopenia is, because there is an entity called pathophysiology wise, if you ask me, you have something called platelet factor 4, PF4. Maybe you can see you have, this is the platelet, I can draw, and there is something called PF4. This is called antiheparin. This is called platelet factor 4. What happens is, this platelet factor 4, sometimes if it's freely circulating, it can bind with the heparin. So let us assume this is the heparin, and this is a platelet factor 4. And remember, heparin per se or platelet factor 4 per se is never an antigen, but the combination of heparin and platelet factor 4 becomes an antigen by a principle called Hampton mechanism. Certain substances by themselves are not immunogenic. When they are combined together, they become immunogenic. This is called Hampton. So they become an antigen, and once they become an antigen, you are going to generate antibodies against this heparin platelet 4 complex. You are going to generate antibodies against this heparin platelet 4 complex, which means now you can tell this is the platelet, and you have this heparin, this platelet factor 4, and you are going to have a heparin, and you are going to develop antibodies against them. You are going to develop this antibodies against this heparin platelet 4. This thing, its antibody are direct against heparin platelet 4 complex, not against platelet 4, not against heparin. That's also very important. These antibodies, you know very well, these are typically IgG antibodies usually, And once these antibodies are formed, number one, they have this FC portion. Because they have this FC portion, they are going to activate the splenic macrophages, reticular endothelial system. In the spleen, they will be cleared completely, which means this is the main reason they are going to result in thrombocytopenia. At the same time, these antibodies are also going to cause platelet activation. And this platelet activation will result in release of a lot of platelet-mediated agents and platelet aggregation and thrombosis. So this is one condition where you have thrombocytopenia and thrombosis together. Remember, other conditions where you can have thrombocytopenia and thrombocytosis together is APLA, antiphospholipid antibodies. Whenever you have antiphospholipid antibodies, here also you will encounter APLA antibodies also cause thrombosis and thrombocytopenia together. Remember, in exam, whenever you encounter thrombosis with thrombocytopenia, please think about only these two conditions, heparin versus APLA. If you have history of heparin use, go for HIT. If you don't have history of heparin use, and if typically a female patient with or without SLE. SLE is a very important associated factor with APLA. It's a secondary cause of APLA, very important. We'll discuss in detail, but very important is SLE. SLE is a very important secondary cause of APLA syndrome. Primarily also it can come. So if it's a female patient, no use of heparin, thrombosis, thrombocytopenia, please go for APLA. If you have typical history of heparin use, thrombosis plus thrombocytopenia, please go for HIT. That's called heparin-induced thrombocytopenia. This is a very peculiar thing. Thrombocytopenia with thrombosis can happen only in two conditions as far as exams are concerned. Then there are two types of it basically. One is called HIT1, that's called heparin-induced thrombocytopenia 1. Heparin-induced thrombocytopenia 1, type 1, and you have something called heparin-induced thrombocytopenia type 2. Clear? So this is non-significant. Clinically, ask me, this is non-significant, and this is the one that is clinically significant. The first one is non-significant. This is the one that is clinically significant. And pathological mechanism, if you ask me in HIT1 versus 2, it is direct mechanism. Direct effect of heparin on platelets, and it's non-immune. It's not related to any antibody like what we saw. And HIT2 is the one that is related to immune mechanisms, which means this is the one that is going to form the typical IgG antibodies that we discussed against the heparin platelet 4 complex. It's antibody mediated. Incidence is 10 to 20%. It is approximately 1 to 2% only overall incidence. But if you ask about unfractional heparin, as we already discussed, is going to be high up to 0.1 to 0.8, 0.01 to 0.8%. Whereas in unfractional heparin it is going to be 2 to 3%, and in low moderate heparin it's going to be 0 to 0.8%, and in fondaparinux it's going to be, very well, it's 0%, which means fondaparinux is not associated with any kind of hit. Unfractional heparin, yes, little bit higher risk, little bit low risk, but still risk is there with low moderate heparin. Okay, then onset typically 1 to 4 days, within 1 to 4 days of heparin use. Usually, typically it happens after 4 days of heparin use, typically around day 5 to day 10. This is the time where you get this type 2 heparin dysfunction. Typically happens after 4th day. That is very, very classic. Even though some cases have been described within the 4th day, but exam wise, it happens after the 4th day, by day 5 to day 10. That's the usual time. Then, when they can develop early, I didn't tell you that. So I told you there are case reports where it happens within 4 days. Clear? So if it happens within 4 days, think about history of prior heparin use. For a short time, in the previous time, maybe for 3 or 4 days, they would have used heparin. Prior heparin use in last 3 months. In the last 3 months, because these are IgG antibodies, they tend to stay for some time. So they would have used heparin only for 2 to 3 days, which means they would not have continued heparin till the time where they develop this type 2 HIT in the last time. Now, when you are continuing for the second time within the 3 months, then already these IgG antibodies are there, and because the immune system is active, now you give heparin for the second time, it might be boosted, and you might have a secondary immune response where the response is faster and quicker. You might get within the 4th day also. But exam you give for more than 4 days. But if it happens within less than 4 days, then consider about prior heparin use within the last 3 months. Very important point, very interesting point also. Then platelet nadir, if you ask me the least platelet, you will get around like 1 to 1.2 lakhs, which means that platelet nadir, the least point of thrombocytopenia will be more than 1 lakhs. but the platelet nadir will reach to less than 1 lakh here, which means the platelet count will drop so low, below 1 lakh in case of type 2 hit only. Remember, there is no thrombotic equivalence. There is no thrombosis here. But here, definitely there is a high risk of thrombosis. And here you can continue heparin. There is no problem. You can continue heparin, no problem. But remember here, heparin has to be discontinued for lifelong, for life. The moment you get any single episode of type 2 hit, you cannot use heparin, and it has to be discontinued for your entire life. Very, very important. And you have to give alternate anticoagulation only. But even though re-challenging is given in a lot of journals, but I am not going to the journal, standard textbooks give only heparin should be discontinued for life. But anyway, some new concepts are coming in journals where it can be re-challenged depending on this antibody titers and all they are seeing. But anyways, I'm not going to talk about, I'm not going to confuse you in by telling all those things. Clear? So this is what you're going to get in hits. And what do you, when you call hits, suppose if you have a heparin-induced thrombocytopenia type 2, plus if you have a thrombosis also in the patient, so this is what we refer to as something called a hits. This is what we call heparin-induced thrombocytopenia thrombosis syndrome. That's called hits. Diagnosis-wise, typically, you need both clinical and pathological criteria. There are two criteria. The other one is called clinical, second one is called pathological. Clinically, platelet nadir will be less than 1 lakh, as I told you, which means it's going to be less than a lakh. That can happen only in type 2, not in type 1. Or you can have 50% decrease in platelets from the baseline. For example, if the patient had 4 lakhs, suddenly it dropped below 2 lakhs. That's also significant. 50% decline from the baseline. Or if the patient has thrombotic manifestations. Thrombotic manifestations, like it could be arterial or venous, but what is more common with HIT is venous thrombosis than arterial thrombosis. Venous than arterial is the most common. So if the patient has associated thrombosis, arterial than venous than arterial, DVT, pulmonary embolism, or you can get MI, stroke and all this, limb ischemia and all, peripheral vascular disease picture. So all these things. Or if the patient has a skin necrosis, that is also equivalent to thrombosis only. Skin necrosis. All these things, typically this is true. I mean, many of the times this happens while the patient is on heparin. That is what is going to give a clue. Suppose if the thrombosis or skin necrosis happens while the patient is on heparin, that is very, very high chance of HIT. Because when the patient is on heparin, you generally don't expect a thrombotic event, you expect a bleeding event, isn't it? But when you get thrombosis or skin necrosis when the patient is on heparin, that's a very high significant point, especially for exams. That is 100% diagnostic of HIT because it's not possible unless until patient has HIT. That is the significant type 2 HIT. Pathological criteria, they have positive hit antibodies. I told you these IgG antibodies can be assessed through ELISA method. There's an alternative test is there, but this is the best. This is the one thing that we use currently. But alternative testing is also there. Alternatively, you can use something called your functional platelet aggregation assay. Functional platelet aggregation assays using serotonin. Platelet aggregation assays using, that's called serotonin release assay. That also you can use actually. Clear? So, but this is what is we prefer. But currently, one thing about this HIT antibody, you can ask me, sir, why I cannot use this HIT antibody straight away. The moment platelet becomes, for example, I'm not waiting for the nadir for less than 1 lakh. Suppose, let us see. This is one very important point. Platelet is more than 1 lakh, but it's dropping. Let us assume platelet is now 1,20,000, which is still less than 1 lakh, which means you consider this the low platelet only, but the nadir is not less than 1 lakh. And plus patient is not having thrombosis. Plus patient is not having heparin. And patient is on heparin. Patient is on heparin. Will you take it as HIT type 2? Will you call it as HIT type 2? I cannot do it. Clear? Why? Because the platelet nadir is very important. That's why clinical is very important. So you can ask me, sir, I'm doing now to confirm it, I'm doing HIT antibody. You told HIT type 1 is not associated with antibody. I'm doing HIT antibody, it is coming as positive. Now with this, can I diagnose? No, again, it's not possible. You need both clinical as well as pathological criteria. Why? Because HIT antibody is not without pitfalls. It's going to have its own negativity. So what HIV antibody, even if HIV antibody is positive, without the clinical background,
I cannot take this HIT antibody positivity as a indicator of HIT type 2 or clinically significant heparin-induced thrombocytopenia. Why? Because this is normally, physiologically, even without any significant HIT, this is present in 20 to 20% of the patients who's already on unfractioned heparin or low molecular heparin. Very, very common. Even if you don't develop it, even if you give heparin to me, I have a 10% or 20% chance of developing these antibodies. But these don't have any clinical significance. Be very careful. Even though pathophysiology is these antibodies, but a lot of patients, these antibodies are circulating, but they don't cause any problem. Only in few selected patients, they cause problems. Maybe related to some genetic events, we don't know. At the same time, it can be seen in almost 50% of cardiac bypass patients. Patients are going for bypass surgery. CABG, coronary artery bypass grafting, cardiac bypass. 50% of the patients generally demonstrate these antibodies in their circulation, but without any clinical effect. So that is the reason why it is very, very important to understand the fact that without this clinical background, only with the help of these antibodies, do not diagnose HIT type 2 or any form of HIT for that matters. Because these antibodies can be false positive. That's what I'm trying to tell. Clear? Their sensitivity is high, but specificity is very poor. They can be false positive. Don't diagnose without the clinical background. Please diagnose with an appropriate clinical background. Next, you have something called so that is why to avoid the confusion, where to use this criteria, they use something called a 4T score. So what are the features that are used in 4T score? Number one is thrombocytopenia. What is the nadir? That's what they see, whether it's less than 1 lakh or more than 1 lakh. Then you can see the timing of the event, whether it's after 4 days or within 4 days. They're telling the probability, it's a probability scale. Then you can see whether thrombosis there are not in the patient. Then you can use presence of other causes, other apparent causes, whether obvious causes of thrombosis is there or not. For example, the patient is immobilized and they are having a hip replacement surgery. That's an obvious cause for a DVT. So that DVT, you can get with heparin, but still I will tell that DVT I won't take it as a really HIT type 2 because there is an obvious cause for a DVT. So other cause also you have to look for. Based on this 4, you can give a score. So the total score is somewhere around 0 to 8 is the total score. Suppose it's less than 3 means almost it's 99% rules out heparin-induced thrombocytopenia type 2. Less than or equal to 3. Which means it has 99% negative predictive value. Which means the score is less than 3 means it almost rules out HIT. It's not possible to have. If it's more than or equal to 4, then you have increased chance of HIT. Increased chance of HIT. If it's more than or equal to 4 means then you have increased chance of heparin-induced thrombocytopenia. Clear? So now, what is going to be the treatment? The treatment of heparin-induced thrombocytopenia. Treatment-wise, management, first discontinue any form of heparin. Any form of heparin. Because heparin can come as a magic, sometimes suddenly in between. We don't have any idea how it comes magically in between is because you have flushes. The sisters don't have an idea that the flushes they use is sometimes containing heparin. And the IV lines that is having you have a triple lumen, tri-lumen cath is there many times. With that only they flush it. So this lumen itself might contain some amount of heparin from the last injection. That also immediately you have to remove that. So any form of heparin, including the flushes, including from the venflons, you have to. In fact, I do replace the venflons itself. Venflons is like angiocaths. That itself I remove completely. Any catheters, any form which has a potentially even a small amount of heparin might trigger dramatic consequences. So remove everything, any form of heparin. First, discontinue them. And very important thing is do not give platelet transfusion. One of the important contraindication of giving platelet transfusion, even in the presence of thrombocytopenia, is HIT, your HELP syndrome, then hemolytic uremic syndrome, and thrombotic thrombocytopenic purpura. HUS, TTP, HIT, HELP. Don't give platelets even if there is thrombocytopenia because high risk of thrombosis. And this also will be destroyed, and more activation of platelets. Even the platelets what you are infusing also will get activated by these antibodies and you are going to result in high risk of thrombosis. So do not give. Next, suppose if the patient what do you have to give? Because there is a high risk of thrombosis in this patient, you have to start some anticoagulant agent. That is non-heparin. So you have to treat a non-heparin anticoagulant agent. Remember, very important point is that this non-heparin anticoagulant should be started. Non-heparin anticoagulant should be started irrespective of thrombosis. Irrespective of whether thrombosis is there or not, it doesn't matter. You have to start this non-heparin anticoagulant for sure. Very, very important point. Irrespective of whether you have thrombosis or not, it has no impact. You have to start an anticoagulant agent. Clear? Then next thing, what anticoagulant you will start? Typically, textbooks tell two things can be preferred. Argatroban, which is a direct thrombin inhibitor, but it's an IV drug. Argatroban IV can be preferred. Or you can prefer one more drug called bivalirudin. This is also direct, thrombin inhibitor, factor 2A inhibitor. Bivalirudin, yeah. Bivalirudin. But textbooks, traditional textbooks recommend this Argatroban IV as a standard, but bivalirudin also can be preferred. It's not like this only can be, but standard textbooks sometimes do mention this Argatroban as a preferred agent. This old one, but anyway. So Argatroban IV. So how long you will give this? Anyone, you're not going to give both, anyone. How long you are going to give? You have to continue this till platelets are more than 150,000. Then you can give warfarin. Once the platelets become more than 150,000, give warfarin and argatroban together. Warfarin and argatroban together, or you can give bivalirudin together. But anyone, warfarin and together, because this is needed for bridging. I told you, warfarin always needs bridging. Then once INR becomes 2 to 3 and stable for more than, INR is stable for more than 24 hours, then start only warfarin. Warfarin only. So how long you will continue warfarin? How long to give warfarin? Suppose in the presence of thrombosis, the patient has thrombosis, or if the patient doesn't have thrombosis. The patient has thrombosis, then you have to continue for 3 to 6 months because it's a provoked cause. So generally we give around 3 to 6 months and we stop because heparin provoked thrombosis. So definitely it's a provoked cause, so 3 to 6 months only. If it's no thrombosis, plus please, before telling it's no thrombosis, rule out occult DVT by doing a venous Doppler. Occult DVT would have been there. Something small DVT which you might not see outside may be there. So rule out DVT by seeing it. So in this condition, you can give subsequent anticoagulation until the platelet count recover. So you can give until platelet counts recover. Plus 2 to 3 months. 2 to 3 months. Suppose if DVT screening is negative. Remember, if DVT screening is positive, you have to go for 3 to 6 months because it's an evidence of thrombosis. If you don't have evidence of thrombosis, you have to give until platelet counts recover. Plus, as a consolidation therapy, you have to give for 2 to 3 months because there is a risk of thrombosis even after, maybe 1 or 2 months. There is a lot of trials which have proven that the patient gets thrombosis after 1 or 2 months also. So that is the reason we we consolidate with 2 or 3 months of warfarin therapy after that. So it's okay. This is how you give. Clear? So this is again very, very important things to understand. All these things. So this is how you treat heparin-induced thrombocytopenia. Please do discontinue any form of heparin for life. Suppose next time when the patient need heparin, for example, patient was developed history of HIT2, which means the patient has developed clinically significant heparin-induced thrombocytopenia. But what will you do next time? They need anticoagulation. History of HIT, which means in the past they had a heparin-induced thrombocytopenia. In the future, they need anticoagulation. They might need, definitely they need anticoagulation for a variety of purpose. What you will do, what to choose, what anticoagulant to choose. Obviously, you cannot use heparin. Definitely not heparin. It's a idiotic thing to use heparin again. No brainer. You cannot use heparin. So what you can prefer for acute settings, instead of heparin, you can use fondaparinux, or you can use even bivalirudin, or argatroban also is preferred, but no, not for that purpose. You can use for acute settings. You can use fondaparinux and bivalirudin. Well and good. They are not having, because I told you fondaparinux is 0% chance of HIT. They don't have any side chains at all to form the complex. And bivalirudin again 0%. There is no doubt. And again for prophylaxis purposes, you can use NOACs. NOACs are well and good for prophylaxis purpose. Again, novel oral anticoagulants are very, very safe. Even warfarin is safe for this purpose. You can use warfarin also if you want. But even NOACs are safe. That's what I'm trying to tell. So only thing you should not use heparin in the future. Patients having, but fondaparinux is also safe. That's what is very important to understand. Clear? So this is how you treat a heparin-induced thrombocytopenia. Clear? This is a very important topic to understand. Heparin-induced thrombocytopenia, that 4T score, the components and all, they might be asking in exam, especially the antibodies, whether it's IgG or IgM, that also they will ask. And what is the mechanism? They will ask difference between HIT type 1 and type 2. And a lot of clinically important relevant points I've told you. So it is very important to study this particular topic because a lot of questions are coming from these anticoagulants. So I've told you in and about all this anticoagulants and related coagulation pathway initially itself. So with this, I think we can finish it off, your particular session, and we can move to the next section, that is your bleeding and coagulation disorders.